Hello, everyone. This is Dr. Sri Banerjee, and in this presentation, I will be going over the link between depression and overall mortality in post-menopausal women in a nationally representative population. So, within the next 10 minutes, what I will be doing is explaining to you our study and providing you with some insights that you can take with you in your clinical practice or also when if you're conducting your own research. This can allow you to understand how to really get into the matter of mental health as it pertains to postmenopausal women. So let's go ahead and get started here. First of all, we have no financial disclosure or conflicts of interest to report. I also wanted to, just for completion, include the abstract within the presentation so that you could take a quick look at it. And then I wanted to start also with this because this is the patient health questionnaire, which is the instrument that was used within the study. And more specifically, depression screening was conducted with these 9 questions. And these are standard questions which are used in most depression screening questions. So the last one is the suicidal ideation question. So here we have kind of an understanding of what is out there in the literature. And as it turns out that there is an association between depression and mortality that has been found. And when it persists over, long periods of time, um, there's, even though there's been a lot of improvement in treatment and reduction of stigma, there's still a lot of uh, we still have a long way to go when it comes to understanding depression. Um, so in one study between 1990 to 2011, this was a longitudinal follow-up. Um, Only women with depression were found to have 51% elevated risk of mortality than those without depression. So in these early studies, Gilman et al. That conducted shows that there is, in fact, a relationship between depression and overall mortality, and that is what we were aiming to look for. However, in a more nationally representative, in a national data set, we were trying to explore these relationships, and more specifically, we were looking for how menopause plays a role in all of these. So, taking a look at what menopause does to the body, you can see that there's fluctuating moods, which of course very much sounds like also how depression and how some of the mental illness plays out as well. So there's problems sleeping, hot flashes, night sweats, and in the next slide, what you will see is that there are many sorts of commonalities between the symptoms of depression and the symptoms of menopause and perimenopause. So the symptoms that are in common, low energy, poor concentration, insomnia, weight gain, decreased libido, these things are seen both in depression and menopause. Now, in menopause, in addition, you will see, of course, hot flashes, sweating, vaginal dryness, things like that. On depression, you also see depressed mood, anhedonia, worthlessness, guilt, agitation, suicidal ideation. So let's explore this linkage a little bit more. Over the course of a lifetime, it's found that depression is twice as likely to occur in women than men. So depression is something that really, really needs to be explored in women. Now let's look at, of course, depression and cardiovascular disease. Very, very important because one of the major causes of mortality within the United States is cardiovascular disease. So, at least a quarter of cardiac patients suffer with depression, and adults with depression often develop heart disease. So, the World Health Organization says that 350 million people suffer from depression worldwide, and 17.3 million die of heart disease each year, making it the number one global cause of death. So, as you can see, both of these are leading to a lot of morbidity and mortality. And the reasons behind this is what we will be going over in this study. So here we have the methods, and you can quickly see here that, uh, you know, the association, uh, we were looking for the association between currently active depression. So if they received in the PHQ-9 scale a score greater than or equal to 10, then they were positive for depression. And so the relationship between depression and all-cause mortality was assessed then. And the follow-up was from 2005 2000, through 2010, all the way up to 2015. So what that means is that some people started within the study in 2005, while others started in 2009, 2010. So about the average follow-up on this data set was about 5 to 6 years. So not everybody had the same start. So let's take a look at the model that is important in this study. And so this is a triangular model, and the all-cause mortality was the outcome that we were after. So that is at the bottom. And the independent variable that we were investigating, of course, was depression. But we were trying to see how menopause may alter that relationship between depression and all-cause mortality. And more importantly, does menopausal status alter that relationship between depression and all-cause mortality? So before we decided to run a Cox regression, we completed some bivariate analysis and found some basic distribution, what they were. And the study participants, there was a pretty even distribution. And if there was areas where certain ethnic groups were not represented, of course, that was compensated within the sampling technique. So this was a diverse population, and so many of these findings are very much generalizable to other populations as well, due to the fact that there was so much care taken to try to make sure to and balance the participants. So this is a distribution of obesity within the study participants on the right, and on the left is the distribution of race. So in this slide now, we have provided some of the most important findings of our study. This reports the hazard ratio according to the category that was studied. So if we start from the left to the left is, of course, the reference category, and anything that is crossing the dotted line is considered not significant. So as you can see, depression is actually significantly associated with all-cause mortality. And this is just with age adjustment. Now, if we try to control for other physical disorders and chronic diseases and demographic factors, even yet, we find that depression actually leads to all-cause mortality. And that is 1.81 times higher chance for people who have depression and are post-menopausal than those individuals that do not go through depression. Now, if we looked at all women, premenopausal, postmenopausal, we did not make a distinction according to menopause status. Then, surprisingly, we found that some of these significant relationships disappeared. And that is what is reflected on the very right. So in conclusion, this figure really sums up what is going on. So depression in cardiac patients, of course, it not only causes impaired health promoting behavior, but also a lot of adverse physiologic effects. So, and you can kind of go through all of these things and see how these contribute to um, an exacerbation of chronic diseases and mental health. So, what are the recommendations that are coming out of this research study? Despite clinical guidelines recommending routine screening for depressive symptoms, there's still varying success in implementation. And so the bottom line is there's an underdiagnosis of depression in women experiencing menopause. So how do we surmount this challenge is we need to make sure that we are doing depression screening, especially for women that have experienced menopause or are experiencing perimenopausal symptoms. Better understanding of barriers to and facilitators of effective depression screening and integration of depression treatment into symptomatic post-menopausal women. So many postmenopausal women, it is a known fact, also have comorbid chronic conditions. And so there are so many medications that are needed in order to address this that sometimes, including an additional antidepressant, um, is some practice of polypharmacy, which, um, as physicians, we're always trying to avoid. So, we have to be aware of drug-drug interactions when antidepressants are being prescribed. So, in conclusion, we have symptoms of depression and physical health, which can be alleviated by hormone replacement therapy. In addition, selective serotonin reuptake inhibitors, these need to be explored. SSRIs and even SNRIs need to be explored. And very importantly, the index of suspicion needs to be high when we are investigating and when we are surveilling depression and conducting depression screening. Thank you for listening to this talk.